This opportunity to talk about our studies. So this is the topic: botulinum toxin in Parkinson's disease and Parkinsonian disorders. My name is Dr. Shivam, and I did my neurology in Cleveland, did my fellowship in movement disorders, did a year of research fellowship at Yale University, mostly researching on neurotoxin, botulinum toxin therapy in different movement disorders. And then I moved to India, now in Bangalore, working as a consultant neurologist there. So just briefly about what is botulinum toxin, and it is as a toxin which is released from Clostridium bacteria, and we know it affects the presynaptic membrane before it affects the SNAP25 protein. As a result, the acetylcholine doesn't get released to the synapse. As a result, it causes weakness in the postsynaptic membrane. Now there are 4 commercial products available for botulinum toxin, and mostly they are ONA, INCO, EBO. These are 3 types of type A botulinum toxin, and there's one type B, which is called REMA. Now briefly about Parkinson's disease, we had heard about it yesterday from the Rodriguez, and this is a very common neurodegenerative disorder. The estimate prevalence is 6.9 million, and as per a recent article in JAMA Neurology, they were estimating that the numbers will increase to 15 million by 2040, and they're calling it a pandemic, Parkinson's disease. The diagnosis is based on the UK brain blend criteria for Parkinson's disease, where you should have at least bradykinesia, which is slowness of the movement, along with rigidity and tremor. Now, we do see other symptoms in Parkinson's disease, which are other symptoms such as dysphagia, drooling of saliva called Sialorrhea, mass facies, non-motor symptoms which are very common like constipation, urinary symptoms, depression, anxiety, pain. These are all the other symptoms of Parkinson's disease. Briefly talking about it, we know there is substantia nigra which releases dopamine, and it goes to the striatum, which causes the normal functioning in the motor pathway. When you have absence of dopamine, it causes a slowing of the system. As a result, you get the hypokinesia, the bradykinesia, rigidity. But interestingly, you have this tremor, which is more of hyperactive disorder. We have Parkinsonian conditions, which is MSA, there's multiple system atrophy, which is a Parkinsonism where you see more of autonomic symptoms or cerebellar symptoms. The second is the corticobasal degeneration, where we see one parietal lobe being more affected. As a result, it causes hemidystonia, one-sided symptoms. And another thing is PSP, the progressive supranuclear palsy. In this, we have early falls as a prominent symptom of supranuclear gaze paresis. These all do not respond very well to levodopa therapy, and the progression rate is faster than typically we see in Parkinson's disease. So, where botulinum toxin can help Parkinson's disease or Parkinsonian conditions, there are many subheadings. So I kind of made a chart like this. So all these are conditions where botulinum toxin can be helpful in Parkinson's disease. There is tremor, cervical dystonia, Sialorrhea, limb dystonia, cambricormia, bruxism, pain, freezing of gaze. So there are many conditions where it can be helpful. Now I just group all of these into one chart where you can group conditions like tremor. All the green are all dystonia conditions, and pain and restless leg syndrome. Autonomic symptoms is overactive bladder, hyperhidrosis, Sialorrhea, and freezing of gait. So I'll be going through these topics briefly, mostly emphasizing on 2, tremor and restless leg syndrome, where we did 2 randomized double-blind studies, and one is already published and one is on the way of under review. So we'll start with the tremor. So Parkinson's disease, tremor, and role of botulinum toxin treatment. We know that James Parkinson in 1817 described this as paralysis agitans, the essay on shaking palsy, where he described beautifully the symptoms of Parkinson's disease. The 4 to 6 hertz tremor, and it is at rest, goes away with action or posture. The key features of Parkinson's: it starts on one side. It is clinically at rest, but it can be seen when you put the hands in posture after delay of few seconds, which is called a re-emergent tremor, and the tremor is 4 to 6 hertz in frequency. You don't see a head tremor in Parkinson's disease, but you see commonly a lips, chin, and tongue tremor, and there's more of distal emphasis and more prominent in hands and feet than more of axial tremor. There was a study done by one of my colleagues, Dr. Machado, who found that the patients who have tremor, dominant Parkinson's disease, they have a very crippling disease. They were really affected. These are some of the descriptions the patients mentioned. My tremor makes me feel negative about myself. I'm embarrassed about my tremor. I worry about the future. I'm nervous or anxious. The tremor also increases their anxiety and their nervousness. And it affects the quality of life in 1/3 of the patients. We know that tremor is the most common presenting symptom of Parkinson's disease, present in 75% of the population. 1/3 patients do not respond to the conventional therapy with levodopa, and thus this is a refractory symptoms in many patients. And this is just how the tremor is. I won't go into the details of this. The medical treatment for this we know is levodopa therapy, anticholinergic therapy, and the medications. But as I told you, 1/3 patients do not respond to the high dose of levodopa, and in these patients we have to do surgery, deep brain stimulation surgery. The targets are mostly VIM and STM for Parkinson's disease tremor. But not everyone gets a surgery. There's eligibility criteria, it's very expensive, and there are risks, which is less than 5%, but still there is a risk. So it is challenging how to control the tremor in Parkinson's disease patients. Then we found some studies, where open label studies, mostly with some number of patients, around 15 patients and around 7 patients, and they found that yes, it can be helpful if we inject botulinum toxin in hand muscles to decrease the tremor, the muscle activity, and reduce the amplitude of the tremor. But there was no randomized study done so far. But they have been done in essential tremor, which essentially it is essential tremor of the hands. So we designed a study where we did botulinum toxin injections in the hand muscles in a customized fashion. Customized fashion means the previous studies where in essential tremor they injected 4 muscles in the forearm only, and that caused significant hand weakness. They had difficulty lifting their wrist up in the air. As a result, we designed a customized approach where 34 patients were injected, 16 in the control group and 18 in the placebo group, and they had a crossover at 12 weeks where they were injected with normal saline. The injections were blinded. They were used under EMG guidance and identifying the muscles which are clinically active. 8 to 10 muscles of the hand and forearm, including the proximal muscles like biceps, triceps, distal muscles like lumbricals were included as well. And the clinical rating scale was used, UPDRS, Unified Parkinson's Disease Rating Score, for rest tremor, action tremor, postural tremor, NIH clinical genetic criteria for tremor score, patient global impression of change, and Parkinson's disease questionnaire or quality of life questionnaire, PDQL. They were all used, and it showed that there was significant improvement at 4 and 8 weeks in both the UPDRS tremor scores, NIH tremor score, quality, and the patient global impression of change, but there was no change in quality of life of the patients. So this is a study where we injected botulinum toxin and showed an improvement in the Parkinson's disease tremor. So we have covered one topic so far. Now we'll go to the other topic. We'll start with cervical dystonia. So as I told you, dystonia is very common in Parkinson's disease patients. Sometimes when we see that as a presenting symptom, we think it's more likely a Parkinsonism, which is an atypical Parkinson's like MSA or PSP. And these patients can have enterocollis, lateral collis, where the head is towards the side, retrocollis towards the back, and torticollis towards the side. So in multiple system atrophy, we see more often enterocollis, and this is mostly because of hyperactivity of the longissimus coli muscles and the bilateral sternocleidomastoid muscles. PSP we see mostly retrocollis, and it's easy to inject with this bilateral splenius capitis muscle. We can inject with botulinum toxin and improve the cervical dystonia in these patients. These are some injection sites on the picture. Limb dystonia. So limb dystonia, usually we see that as a sign of young onset Parkinson's disease. Young onset, like in patients who are 40s, 45, 50. We see then when they're walking, they will feel their feet turns inside. They have a very prominent toe flexion, the equine varus position, and we call it limb dystonia, which can be a presenting symptom in young onset Parkinson's disease. Also very commonly in CBD, corticobasal degeneration, which is a Parkinsonism, we find one-sided hemidystonia. So botulinum toxin can be used in these conditions to improve the personal hygiene. When they have a clenched wrist like this, there's a very poor personal hygiene. So with botulinum toxin, we can open up the hand muscles, fingers, and clean that area. Also, we can give some physiotherapy, physical therapy, occupational therapy along with that to improve the quality of life. Also, it is very painful. Sometimes painful dystonia is a very prominent symptom. With Parkinson's, we see as an off symptom, as an on and off state. In the off state, they will have painful dystonias, which improves again if they take the levodopa medications. But if these fluctuations happen very frequently, botulinum toxin can be used. And recently there was one study that was published by Dr. Digos in 2017 Parkinson's and Related Disorders Journal, where he used INCO botulinum toxin, Xeomin, for the foot dystonia in an on and off state of Parkinson's, and he injected 100 units in flexor digitorum longus muscle. This is the only randomized study for foot dystonia so far. There are a few open label studies, and it's a very large population, and they all seem to work very well for dystonia conditions. So this is a good indication for dystonia. Coming to Blepharospasm and Eyelid Apraxia. This is a condition which we see most commonly in PSP conditions where progressive supranuclear palsy, where you have dystonia, focal dystonia of the eyelids, and sometimes it can be mistaken as eyelid apraxia. And we inject ONA botulinum toxin, Botox, or INCO, which is Xeomin, and it's around in the orbicularis oculi muscles in multiple sites, as you can see. And this works very well. This works very well for the essential blepharospasm as well, who do not have Parkinson's, and this is actually a level A evidence for using in blepharospasm, one of the first indication by US FDA. Now coming to, we already covered this. So Bruxism and Oromandibular Dystonia. This craniocervical dystonia, we commonly see that multiple system atrophy, and these patients will have jaw closing dystonia, jaw opening dystonia, jaw protrusion, and all these problems, which can be very difficult for the patient when they have difficulty eating food, chewing food, and really affects the quality of life. And in these patients, we can inject muscles for jaw closing. We need two muscles, which is the masseter and the temporalis muscle. For the jaw opening is the bilateral lateral pterygoid. Jaw sideways deviation is an ipsilateral masseter and contralateral lateral pterygoid muscle. And multiple open label studies on this as well. Around 162 patients with oromandibular dystonia, study by Dr. Jankovic group, where they injected botulinum toxin, and there was an improvement on a scale of 0 to 4 up to 3 grade, and around but 11% had dysphagia and dysarthria. There's a condition called hyoid muscle dystonia, which is published by a group at Mayo Clinic, and they describe this condition where patients have anterior neck tightness, dysphagia, and dysarthria as a presenting symptom, and had a significant improvement with hyoid muscle injections. These are some common sites: the temporalis muscle, masseter muscle, lateral pterygoid, the medial pterygoid muscles. So freezing of gait, we have all heard about this. This is very common, most common reason of the patients to fall with Parkinson's, because their feet get stuck to the ground, and as a result they cannot move. It can be an off phenomena during the motor fluctuations. When the dopamine level goes low, you can have the off phenomena. But commonly we see that as an on phenomena as well, when the dopamine level is high. And we really don't have very good treatment for freezing of gait. Mostly with visual cues, with motor cues, you have to tell the patient to rhyme left, right, and march and walk, which helps them to walk and helps them to avoid the freezing. So people have studied use of botulinum toxin and freezing of gait as well, and they feel that this is likely the involuntary contraction in leg muscles, and why not give injection to leg muscles and see if there's any improvement. There was one study which showed a significant improvement where they injected bilateral like gastrocnemius muscles, soleus muscles, and improved 40% patients had a significant improvement when they were followed for 6 weeks. But this was not reproduced in other clinical trials, so its clinical use is limited and it's not very clear. So we need further studies for freezing of gait. Now coming to the overactive bladder, this is a very common symptom of the Parkinson's disease. Patient comes to you and say, "My doctor, I have urinary frequency, urgency. I have to go to the bathroom all the time. I wake up at night because of nocturia." And this is present in 71% of the patients. This is a very common non-motor symptom of Parkinson's disease. The first line treatment is again anti-muscarinic agents such as oxybutynin, but again this is anticholinergic. So elderly patients will have confusion, more problems, hallucinations. I've seen patients who are completely confused with even a small dose of oxybutynin. We can use sulfanicin, derifenicin, but again these are all anti-muscarinic agents. The newer agent, mirabegron, is promising. It is a beta-3 adrenoreceptor agonist. Also, other part is it raises the blood pressure. So Parkinson's patients have low blood pressure. So this medication adds on and helps with the blood pressure as well. But we have very good studies showing botulinum toxin helping in overactive bladder, which with a dose of 100 to 200 units in detrusor muscle. And if you think why this will be helpful in overactive bladder is these patients, if you can go look at this, there's a detrusor muscle hyperreflexia. As a result, because of the basal ganglia and the frontal lobe function, it controls the sacrospinal cord bladder function and causes the hyperreflexia or the hyperfunctioning of the detrusor muscle. Botulinum toxin, as it paralyzes the muscle, it is helpful if we can make the muscle less active and increases the storage volume, thus decreasing the bladder urgency and frequency symptoms. There's a level A evidence for use in overactive bladder as per the American Academy of Neurology based on class 1 studies. So Sialorrhea, drooling of saliva, hypersecreted disorder is another thing that we see in 75% patients of Parkinson's disease. And again, these patients are really socially handicapped. They see the saliva drooling, they have the napkins attached to their shirt because they have drooling of saliva throughout the day. And this can be really bothersome to the patient and the family. We know that botulinum toxin injection into the parotid glands under US guidance or under just anatomy landmarks blindly significantly improves. There have been studies with botulinum type A and also type B, which has shown improvement. I mentioned it here. So the doses of around 1500 to 3500 units of type B Botox, otherwise doses of 22.5 per gland in the parotid gland is helpful in these patients. The most common side effect is dry mouth, which we want in these patients. So hyperhidrosis or this is the sweating. I'll show you a picture. So the patients, they can have autonomic dysfunction where their hands are always wet and they have a lot of sweating. This can be palmar, axillary, plantar, and patients with Parkinson's are known to have these autonomic dysfunction. As a result, around 64% patients of Parkinson's will have some sweating disorder. For essential hyperhidrosis where we do not have Parkinsonism or Parkinson's condition, we know that botulinum toxin is helpful in this condition as well. And otherwise, first we try with the conventional treatment. There's some atropine drops in use. You can use aluminum chloride, hexahydrate, which is antiperspirant. But when it's really severe, it's very difficult to control the symptoms. And as a result, you have to use botulinum toxin in a pattern used and shown in this picture. So subcutaneous injection of botulinum toxin for plantar, palmar, axillary hyperhidrosis. And as per the AAN guidelines, there's level A evidence for use in axillary hyperhidrosis. There are 3 randomized studies and several open label studies which have proved the effectiveness in axillary focal hyperhidrosis. So we have covered these 3. Now I'll come to restless leg syndrome. So restless leg syndrome, this is the most common movement disorder with a prevalence of around 12% in the population. And we usually see this in younger population. We see also more in females, the menstruating age group. Also we see that patients, the diagnosis is not correctly made and misdiagnosed for neuropathy, for other reasons. And the patients really suffer. If you ask the symptoms, it's very easy. The patients will say that at night time my symptoms get worse. I have this creepy crawling sensation in the legs, which legs hurt, they cramp. They get better if I move my legs. If I walk around, it gets better. And it's worse in the evening, it gets better when I wake up in the morning. So this is typical symptoms of restless leg syndrome. And we know this is a sensory motor disorder. It's a neurodegenerative condition where we see the cause is unclear. We say it's either cerebral, brainstem, spinal cord, peripheral nerve, no one knows. But we know that the TMS, transcranial magnetic stimulation, the supraspinal areas have improved the symptoms, and the pathophysiology is still very unclear. We don't know where the generator is. It is commonly comorbid with Parkinson's disease, although the exact pathological mechanism of RLS is unknown. Dopaminergic medications for Parkinson's disease, such as pramipexole, ropinirole, roticotin, they act such as, and also levodopa, carbidopa, they symptomatically improve the symptoms of RLS. So there is definitely some association between RLS and Parkinson's disease. The current treatment is very effective for restless leg syndrome. Dopamine medications and two delta calcium channel ligands such as pregabalin is helpful, and checking ferritin, making sure that iron levels are normal in these patients is always very helpful. Also, patients who have ESRD, end-stage renal disease, have more prominence of restless leg syndrome symptoms patients. Now, RLS symptoms remain unchanged or worse in 45% of the patients who receive the medications. So, around 50% patients still have symptoms, even after taking the best medical management. So, there are some open-label studies done where botulinum toxin has been thought to improve the symptoms of restless leg syndrome. And now the question is, why it will help the pain symptoms? Botulinum toxin blocks the release of acetylcholine, which is a neuromuscular junction. How will it act on the nerve, on the sensations, pain fibers? How does it go through that mechanism? A lot of studies have been done, which have showed that botulinum toxin decreases the release of CGRP, substance P, and other neurotransmitters, which are key in transmitting pain signals. And that's how it's been used in migraine patients. There have been two randomized double-blind studies, the PREEMPT trial by the Philadelphia group, which has been very positive for migraine. There are other studies for trigeminal neuralgia, post-operative neuralgia. The class 1 studies have been done. Now we know that it is very helpful in pain conditions, and its use in pain is evolving day by day. So there's some evidence for it. There's some studies as well. Some pilot studies, some open-label studies, one randomized study, which this study was negative, and two open-label studies was positive. This negative study had only 6 patients. It was a pilot study by Dr. Hallett group. So at this time we are unclear, does it really help or not? And so we did a study. It's a randomized double-blind study we did at Yale University, and we injected patients with severe RLS symptoms with either normal saline or INCO botulinum toxin. And these patients had, just quickly go through that without extending too much to the details. The patients were injected at baseline and at 12 weeks, and this was the study design. And the patients the only patients who had severe restless leg symptoms had an improvement to mild to moderate at 4 and 6 weeks. This is the use of the Toxin rank test, and we found the quality of life improved at 4 weeks, but not at 6 weeks. The visual analog scale of pain, it improved at 4 weeks, but not at 6 and 8 weeks. The Epworth sleepiness scale did not change at all, and the patient global impression of change did not change at all. So this is a small study, and we should see more bigger studies doing these the trials on Restless Leg Syndrome. So this one is the largest double-blind randomized placebo-controlled study for use of BoNT and Toxin in Restless Leg Syndrome, and for patients who have severe RLS symptoms, use of BoNT and Toxin can be done to see if there's any improvement in the symptoms, the leg pain symptoms. Also, quality of life improved significantly at 4 and 6 weeks after BoNT and Toxin injections. So, this coming to the last, but not the least. So this is the Parkinson's and the pain. As I told, this is very common non-motor symptoms, and it may affect around 40% to 85% patients. There was a recent study where they found that Parkinson's patients report more pain symptoms because of paresthesias, impaired pain perception. So any pain that is perceived by a normal person, it gets amplified in patients with Parkinson's disease because of the low dopamine state. And as a result, this was a study which clearly shows there's twice the risk, 30% in normal, 30% in normal versus 30% in Parkinson's and 12% in normal patients. There was a higher frequency of paresthesias. Impaired pain was 40% in Parkinson's and 20% in normal patients, normal people. So we really know that these patients are more susceptible to pain, and pain can be because of dystonia, musculoskeletal, neuropathic, central, and restless leg associated or atypical in origin. There was a study done at the University of Toronto where they found 81% patients with pain reported benefits after the first injection, and the effect was maintained in the last recorded visit. So it's the only promising study in Parkinson's patients. We have published quite a lot of paper on pain and Parkinson's, pain and use of BoNT and Toxin, with mostly focal pain after surgery or radiation. Another study that we published is the open label study, and there was a review of review of literature of BoNT and Toxin treatment for neuropathic pain, and it's very promising. I just had one patient in Bangalore who had 20 years pain, and there was a post-surgical pain in the groin region after the hysterectomy, and she had pain for 20 years. She had all the nerve blocks. She went to multiple hospitals, multiple treatment, multiple surgery. She had no improvement. When I examined her, I found that at the scar area there was all the hypertrophy in that area. The scar tissue was very sensitive, a lot of allodynia in that area, and injected BoNT Toxin in that area, and she had significant improvement. She is still very grateful. She will just come twice in a month just to come and meet me and say how she is doing, how well she is doing. It's a really inexpensive treatment other than just one cost of the medication, and very less invasive as well. So future directions, the list seems endless with the advent of new indications for the use of BoNT and Toxin in neurology. There's a lot we can do for our patients with Parkinson's disease and Parkinsonism to improve their quality of life. These are my mentors, Dr. Oromandibular, Dr. Eduardo Machado at Yale University, Dr. Eric Elskog at Mayo Clinic, who taught me everything about Parkinson's disease, Dr. Matsumoto, who taught me all the injections with BoNT and Toxin, and Dr. Poon, there are many more who are not there in the photos, but I acknowledge all the mentors, and thank you. Any questions I'll be happy to take.